Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Andrew and Rick. How are you guys doing today?
Doing good. Thanks for having us.
Hey, thank you.
Hey, doing well. Doing well, Dennis.
Nice. So, Andrew, since this is the first time on your podcast, everybody's already heard from Rick, so nobody wants to. But Andrew, if you could do just a real quick introduction of yourself.
Yeah. So my name is Andrew Shafrina. I'm an emergency medicine physician currently with a small surgical team out of Fort Liberty, Fort Bragg. Got a handful of deployments under my belt. As an EM physician, obviously my point of view is going to be focused on the medicine side of things. But excited to be on and share some of the things that I've seen and I've learned, and to be here with Rick Hines. It's an honor to be on the podcast. Thank you.
Hey, thank you. And today's topic, and the reason why I asked you and Rick as well coming on, is we're going to talk about triage. And I think at first, let's handle the medical aspect, and then we can make things like way more difficult later on. But since I've probably started training medics, since I've started being a medic myself, I have a sneaking suspicion that I did not learn how to do triage really well, nor did I practice triage really well. Literally every patient has been urgent. The evacuations always come on time, and nothing really bothers me or gets in my way. And luckily everybody lived. So I don't think that that's necessarily true in real life. So
Probably not.
Yeah. So I think what I'd like to tackle first, one, like what are the triage categories? And say we have, 3, 5, 7 casualties, like all at once. How do we sort through them, get them into the piles that they need to be in, and start doing good medicine? So, Andrew, would you mind starting off?
Yeah. So, the first thing up front, there's no perfect answer to that question, right? So in a multi-casualty or a mass cal situation, the medicine is never going to be perfect. The triage is never going to be perfect. It's chaotic and unpredictable. And so I guess my kind of really cutting right to it answer to your question is, how do you combat the chaos and the unpredictability of having that many patients and only a couple of providers? You use the simplest, most intuitive method possible, right? So you asked how many patient categories. So, traditional triage methods, whether you're looking at the Ranger UPR, the START, the Sieve, some of the NATO or the UK methods usually are using 3 to 5 categories, but 4 tends to be the average. Usually a priority 1, 2, and 3, which can be urgent, priority, routine. It can be immediate, delayed, minimal. And then there's usually a category for expectant. So in practice, though, especially at the point of injury, that initial receipt of undifferentiated patients, these systems that we train on, they're very linear and they're very, patient and vital sign focused. And they take time, usually somewhere between 30 seconds and a minute on a single patient. And that's moving pretty quick. And I guess the reality is, when it comes to what is someone going to die from right away, right? So massive hemorrhage, loss of airway, that's time. If you have 10 patients, that's 10 minutes. That's 9 minutes that you're not getting to that final patient. I guess kind of to drive the point home, because, it helps me to frame it around kind of like a story that I can relate to. And for me, I had one experience about 2 years ago that kind of crystallized all this in my head. So I was involved in a helicopter crash on a deployment during a nighttime operation, and we had 22 people on board. After the dust settled and me and the people that could walk pulled everyone out, I remember, going back in, grabbing my med kit, and looking out, and everything's still dusty, right? Because the helicopter had just crashed. There's some fire that's providing some light, and it's super dark, and a lot of people are yelling. And I just remember thinking like, oh man, there's upwards of 21 people out there. And I at this point, I had found out that everyone else from my medical team wasn't able to walk. So I was like, it's just me for now. And I was like, I don't have time to use these methods that I've been taught. So I had to kind of think on the fly. And really what it comes down to is I need to find out who's dying right now and who's not dying right now, right? So who's urgent, who's unstable, and who's non-urgent, who's stable in this immediate period. So I essentially just ran up to every casualty that I could, and I did a quick blood sweep. I asked them to take a deep breath because that let me see, hey, they're moving air, okay? And I could just evaluate very briefly their respirations, check the pulse, and then if everything looked good, I told them that they were going to be okay, and we had them, and I moved on, right? And each of those took about 10 to 15 seconds. So, and at the time I thought I was going off script. And then, at this point now, I've seen the research from Stephen Rush, Stacey Shackelford, Mike Remley, Rick Hines, Kamlerton, all this research in the last couple of years that is saying that in practice, in these point of injury, like first contact, large patient volume triage, that's what people are doing. They're not using these algorithms that are more rigid and linear. They're really just using a binary triage, like who's dying now, who's not dying now. You're focusing on those life-saving interventions. And what that lets you do is and this is a paper that Stephen Rush had published, is focus on what are the critical things in a large patient, like point of injury, mass casualty incident. It's move, treat, transport, right? Get them away from the danger. Treat the life-saving interventions, like focus on that massive hemorrhage, that airway loss, and then get them to a CCP or get them to that next level of care. After that's all done, once we've done those things, then we can use a more, one of the more linear or more rigid, algorithms that we're all taught and really start to dice it out into those 3 to 4 categories. But anyway, so I know I just kind of rambled on a bit about point of injury triage, but that's my experience. And that's what I think most of the research is heading towards right now.
No, I think that idea, just do a quick blood sweep. So you get your massive hemorrhage, take a deep breath. I think that might be, there's a bunch of reasons why somebody be breathing really rapid and not necessarily real deep. But at least they're moving some kind of air, and then check a pulse, strong, fast, weak, like what's going on. I think that's a really good technique. I would like to know of those, like obviously massive hemorrhage. Okay. That's a real good indicator that something bad has happened. But like the deep breath, the pulse, I guess, how did you quantify stable, not stable?
Yeah. So, at this point, it was more about, are they moving air? Do they have massive bleeding? Do they have a pulse? So I was keeping track if I thought someone had, if I saw, they got a really bad, looks like they have an unstable pelvis, or that their leg is mangled, or that they had a really thready rapid pulse. I was keeping track of that, but really that I wasn't trying to nuance the like P1, P2, P3, like 3 to 4 category system. It was just, are they dying right now? Do they need a tourniquet? Do they need an advanced airway, or for me to clear their airway, soot, debris, what have you, put them in recovery position? And, keeping track in my head of who I wanted to evac first. I'd say I got to about 12 of the patients. Now there were, medics had arrived about 4 or 5 minutes in. We thankfully, ended up nearby-ish to a facility that had a small roll too. And trucks started arriving, right? So at that point, I started getting people out of there. In total, I want to say we had about 12 to 15 litter patients. And of those, there was one person needed tourniquets, one had a flailed chest, one had what appeared to be a moderate to severe TBI at first. And then we had about 3 pelvic fractures. And someone else had identified I did not get to the patient with the massive hemorrhage. Someone else actually got to that one, by the time I was on like patient 9 or 10 of the ones that I had gotten through. But again, so even, in the 5 minutes I was there, I hadn't gotten all the way to that patient. Thankfully, we had lots of, both, non-medic first responders, which again are super important in these mass cal situations, and, medics that had, launched at the site of an incident and ran to the scene. So,
no, I think that I think that one of the things you look at is triage is basically sorting and prioritizing your treatments and your evacuation, kind of at the same time. And it's not a one and done. It is a continuous thing that even when you get to the last patient, if you have that time, you're going to start over again, and you're going until you get everybody out, everybody to other care, to more resources, resources they need. And I know, in our older doctrine, triage was done by the most senior medical person on the ground at the site. And through experience, I've found that that's not always the best use of that senior medical person. If your senior medical person is a surgeon, then maybe he should be doing something else. Maybe somebody else can run triage while he does something else. I know in your situation, Doc, you were the guy. And you had a overwhelming, the definition of mass casualty is that it is overwhelming. So there is no, doing it right. You're doing the best you can. If everything were right, you wouldn't be in a mass casualty. You would have all the assets. You would have everything you need. So when you're looking at doing that, running to the helicopter and finding the mass casualty kit, which I'm sure you had with you, probably is not an option. And so, you grab what you got and you start sorting out and doing a quick assessment. And as people show up, you start assigning tasks to them and utilizing them to get stuff done. At least that's my experience of it.
Yeah. Utilize the resources available. Probably not just, tout your leadership and tell everybody to stand by. Start designating people, hey, help that guy over here. Tell me what you see. If they happen to have no medical knowledge whatsoever, to help organize things. So, the technique just to initially organize people, hey, this guy's dead. This guy's, going to be just fine. These, 2, 3, 4 people, they need some actual attention. For evacuation categories, you have your urgent, you have your delayed, you have your routine. I mean, I don't need to send a guy who has hemorrhage controlled with an extremity tourniquet immediately to surgery and put the burden of multiple patients on them when we have everything under control. We need to send, the broken pelvis or the penetrating trauma to the chest that I can't control that. They need to go first. So I guess how does this kind of idea of, dead, not dying, wanting to die, into those evacuation categories? How do you recognize this guy needs surgery?
Yeah. So, that's a good point. That's a good transition into, I guess, so when I look at the triage, we talked about first contact, undifferentiated patient triage. That's the first pass, right? And then once that is over, once life-saving interventions have been applied, once you've moved to a CCP, then you can do that more deliberate touch and start to delineate more into these, these urgent priority routine. That's what I use, whether or not people use DIME or P1, P2, P3, or the USA, the unstable, stable, ambulatory. But I think of it UPR. And I think that's the format that the T-Tri-C and the COT-C committee are moving towards as well. So as far as how you do that, how you decide who needs surgery. So you can use the algorithms I talked about, right? So your START, your SIEVE, your military SIEVE, your SALT, your RAMP. All these are decent starting points. But the studies show that none of them are really more than 50% accurate, right? And most of them perform a lot worse, a lot of over triage, a lot of under triage. And again, these are good training tools. They're academic tools, but it's like trying to fit a square peg into a round hole, right? And so instead you rely on your clinical judgment, right? Which is why, while it may not be the most senior physician or senior medical provider, medic, etc., you want someone who has experience making these decisions, because you're going to use that clinical gestalt to shape that square peg to fit through that round hole, right? So the way I look at it is I kind of focus on trying to really differentiate that stable, unstable vital signs, and then also consider mechanism of injury. So for me, those urgent patients are those patients that need either damage control surgery, so not definitive surgery, right? We're not talking like going in and doing a full, bowel anastomosis. We're talking about who needs damage control surgery or damage control resuscitation. And really what I'm looking at there is, do they have a serious mechanism of injury? So penetrating chest, severe blunt head, high blunt mechanism of injuries like a rapid deceleration, a crash, they're crushed, large burns. And again, who needs that within the next hour? And that's really the people with unstable vital signs. So that's super rapid pulse, a thready weak pulse, really high respiratory rates, they're really tachypnic, or their mental status. That's honestly one of the biggest ones for me, is when someone's mental status starts to decline. That's one of the last signs that they're becoming unstable before they start really entering that unsalvageable territory when they go too deep into a loss of organ perfusion. So my priority patients, so my second category, these are patients that have a serious injury that will likely need surgery and resuscitation, but their vital signs are looking okay. So these are people who, for example, they've got a tourniquet applied, they've gotten a unit of blood, and now their respiratory rate's good, their pulse is good, they're mentating. I don't have to send this person to DCS in the next hour, right? You're penetrating trauma to the chest or belly that otherwise is looking stable. I may put those patients in the urgent category depending how bad it is. If it's a peppering from a remote blast versus a gunshot wound, that's kind of where that mechanism of injury in my clinical gestalt may shift them into urgent, even with stable vital signs. But then again, head injuries that have any sort of altermental status, even if it was temporary. And like I said, that, or significant fractures. And I mean here, like, kind of higher fractures. So not necessarily ankle, wrist fractures, but I'm talking like femur, pelvis, suspected neck or spine, bad clavicle fractures. And then non-ambulatory patients, usually are going to go into this category. Eye injuries is one that I left out. And then routine is your walking wounded. And the important thing here, is that the routine, these walking wounded patients, your routine or your third category, your minimal patients, they may not present right away. In the military setting, these people will often be the ones providing security, or they're going to be your non-medic first responders. In my experience, the minimal patients usually present 30 to 45 minutes later after all the priority patients have been evacuated and taken care of. And they're like, oh, by the way, I got this cut on my back. So you may not even recognize them right away. And then, the last thing to say about this is, there's rules out there. I know there's rules about what the time to needing surgery or the time to needing evac is. But at the end of the day, clinical gestalt trumps everything. If someone would otherwise meet all the criteria for a priority, but you just think like, this looks bad, I think this patient might be sicker, trust your gut and move that patient up to the urgent category. And then, the only thing I talk about is, you mentioned that in training, we often have, almost every patient is urgent or priority. The reality is, because of survivor bias, in most mass cal or large number of patient scenarios, 75 to 80% of your patients are going to be in this routine and priority category. So just know that that's going to make up, while the urgent patients will take the bulk of your work, they probably won't make up the bulk of your patient numbers. Well,
that's good.
Doc, we can't send that bird to you because you listed this guy's priority, and that's 2 hours. We have to wait for that 2 hour window to send the bird to pick him up, right? I think that the time limit I guess it's fine doctrinally for planning, for commanders and whatnot, but the reality on the ground is, you're urgent, you get out first, you're reassessing, you're converting tourniquets if you can, you're doing whatever additional treatments you can for the patients, and you're reassessing, and then you're going to, as evac is available, you're prioritizing who's going next. And sometimes it's, the aircraft gets a vote. Hey, we can only take 2. We can take 2. But I got 4. We can take 2. Oh crap, which 2? All right, I've got to make a decision here, and I've got 30 seconds. to make a decision, get them loaded, and get these guys out of here. And so yeah, I'm being the lazy medic. I'm gonna put the guys that require the most work on the bird, and the guys that require least work stay with me because I don't like to do work.
Right. Or I mean, even if it just resource wise, you feel like I can handle this guy more than I can this guy. This guy is a bad TBI. I really don't have much to do that I can fix that. This guy I have 2 units of blood. I can still run on him, or whatever the case may be. I feel like I can run with this one longer than I can with this one.
Yeah, and that's a really good point. So I myself as an ER doc, sometimes my decision for who I think is sicker is who can I not manage myself, right? So for me, I'm not a surgeon, so I'm not going to cut on anybody, and I'm not a neurosurgeon, and not to mention attempting any sort of neurosurgical intervention out of CT is risky, right? So you're right. Any patient that I can't, that I don't think my skills can handle, I'm automatically going to want to get them evac'd sooner. If I think that, again, they outstrip my capabilities.
Yeah. And initially, the old, hey, if you can stand up and walk over to that guy and have your, somewhat teachable C trained, buddy, teammate, sort them out while you look at the ones that can't walk. And then he can send the ones that are, really not too bad off back to you, and they can be helpers. Until you get better help. Until you get better help, you start getting guys out and whatnot. I mean,
yeah. And this is just our secondary assessment we're talking about right now. As this time rolls on, people are going to be shifting back and forth as they either compensate or get better or they get worse.
Yeah, and as we're talking here about evac and about these, handing off responsibility to other people, I think this also kind of drives home the point of, whoever is the medical leader in terms of these patients that are actually being triaged and treated at the CCP. They need to make sure they maintain an up and out mindset, right? Because those decisions on who's getting evac'd and accountability for those patients that are leaving, has to be a coordination with whoever the team leader is, whether that's a ground force commander, a team sergeant, XYZ, someone non-medical is the leader in charge of the communication to hire, the accountability of the patients, calling in the evac. And if you as the senior provider are so medicine focused that you're just down and in with the patients, you're going to lose situational awareness, and you're not going to be able to inform those decisions to ensure the best possible treatment and evac triage for all the patients.
Yeah. Not to mention just keeping the paperwork organized. Like, you probably, as all this assessments going on, you probably should be writing some of it down, because those handovers, those can be pretty dangerous for your patient if, information is not passed that's important.
Yeah, we all remember, Dennis and I remember, Nate Always story from Ghazni, where he had the partner force guys. They were, he had a mass casualty, and they're getting medevac guys out, and the host nation guys, it was a bad place. They didn't want to be there. So they volunteered to be litter bearers. And as they're walking to the helicopter, they're putting a little bit of blood on them, and they hey, and they get on the bird. And then pretty soon he's got Colonel Shackelford calling him up going, hey, why didn't you just send 30 guys here that aren't wounded? And he's like, what are you talking about? And all of a sudden he has no more uplift or no more partner force, or almost none, with him. And now they're, yeah. So, these things happen, and to have control of that, who comes in and out of that CCP, that's great once you can establish that. Initially, you usually can't. The other thing is, setting up where the CCP is. So initially, your patients are going to be wherever they land, and they may be scattered about. And, I know, some of my experiences, I started out running around like an idiot, going to each patient. Then finally, I'm like, bring them to me. This is the CCP. Bring them here, and had them all brought up. And then I could sort things out much more efficiently. So, I mean, it's
always good to get your steps in, but let's conserve our energy and put it forward towards something, good. But you're talking, Rick, about guys coming in and out. Okay. Obviously, going out to some kind of evac platform, those are great. Guys coming in, not necessarily great, because you have people that you may know and you may not know. And the ones you know, great, you can organize them and have them occupied with work. The people you don't know, they may be well-intentioned, they may not be. So this, we're talking the medical aspect, but there's like this whole danger aspect to it because somebody caused whatever happened, more than likely. How do we keep them out? How do you incorporate like security? Who's searching people? How do you incorporate that as well?
Yeah, that's a key thing incorporating it when the event happens. For most of us, we're not going to think of that. We're going to see hurt people. We're going to see patients. This is something that has to absolutely be addressed in training with leadership, with your teammates. It has to be addressed in training, because once we have casualties as medical folks, we're going to focus on them. Are we going to have the bandwidth and the wherewithal to remember that security thing and oh, hey man, can you go set up a checkpoint here and track in and out? No, it needs to be a battle drill.
Yeah, absolutely. And at least in my experience, like nobody didn't want to work, right? The team sergeant or the Bravo or something like that, like when you tell a Bravo, I need security, like I got this. But maybe on the civilian side, on the other hand, you might not have that, and mass casualties happen also a lot on the civilian side. So that's where your police, your other first responders can kind of come in. Hey, we need to control traffic. We have bystanders wanting to come in to help. They want to come in and make TikTok videos or whatever the craziness is going on. But we need to get these people either out and keep them back.
Well, the other aspect of that is the highest ranking person never shows up at the beginning. You'll have people of different grades of rank show up at different times and try to take over. And they will, even if they know what they're doing to a certain extent, they'll want to start all over. And if you ever lost a pair of knots on Luzon DZ, you will start the search over again as each person that outranks the last shows up. It's kind of the same with this. You can have, and especially in the civilian setting, you'll see somebody shows up. Hey, I'm the scene commander now. I'm in charge. Okay, great. I've been working this, but sure, you be in charge. And then somebody that outranks him shows up. Hey, I'm the scene commander now, and I've got more assets. Well, okay, fine, great. You're in charge. I'm busy. I'm working. So that is absolutely something to deal with. And if you can have somebody that can screen your personnel in and kind of deflect that to and maybe utilize them, by all means, utilize them for their assets and all that. And then you can have somebody that can manage that traffic so that you can focus on patient care.
Yeah. So, just as we're talking about security and we're talking about leadership, I think it's, especially as someone who's, again, like me, who's very myopic on medicine, I think it's important. And this is something that I try and hammer home whenever I teach this, like, medicine, like the treatment triage aspect of this is just one leg of a much larger table that is mass casualty management, right? It's a leadership driven process that includes security, patient movement in, patient evac out, treatment, triage, logistics, and distribution of resources, distribution of providers, command and control of the scene, communication up and out, communication down and in. And then if it's military, and even civilian, the ongoing mission, right? So, military side, maybe, hey, even though this patient event happened, we still have to complete objective XYZ. On the civilian side, maybe the disaster, the mass casualty incident, whether it's a natural disaster or a man-made incident, maybe that's still an ongoing threat. So again, I just think it's important to realize, because I think sometimes when we train this medically, we train this in an isolated box, and we assume that we are the star player, we're the coach of the team, but that's not the case, right? This is a leadership-driven process. We are just one leg of a much larger chair, or table. Sorry.
Sure. Either analogy works, I think. We just talked about dealing with a large group of people, all at once. I think also potentially even more common, especially for a group like you, Andy, or Andrew, and like the ER. You get two casualties, then you get a radio call. Hey, we got 2 or 3 more, and you get another one. Hey, that group is 10 minutes out. We have another group right behind them. They're 5 minutes later on. Like, I'm guessing you're going to use the same process, but like resource wise, like medical decision wise, who's going to surgery, who are we going to wait and see on, like, I guess, how do you handle that? That's a good question, isn't it?
It is. It's a good question. And I don't have any answer that's going to be this is the answer that I do every time. So triage is dynamic, right? So we're always re-triaging patients. And if all the patients I have are relatively stable, they're responding to their, we did our March survey. Maybe they need blood. Maybe they don't. Maybe they just need pain meds, or maybe they need a tube thoracostomy, or they need to be put in the recovery position. Maybe they need to be given blood after they get a tourniquet. If they're improving, then maybe those are patients I don't have to commit right away to evac or commit right away to surgery. And I think that the question also depends, like, what resources do I have? Like, do I have only 2 units of blood? Okay. But do I have the ability for a walking blood bank? So maybe it's not necessarily I need to hold those resources in case more patients come, but maybe I need to activate my follow-on resupply plan for various contingencies. And the other thing I'll say is, you can only treat the patients and triage the patients you have in front of you. I can't, in my opinion, I can't withhold care because of what might happen, right? Because maybe the other patients that may be coming, maybe, unfortunately they don't make it there. And now I've withheld care on somebody, for a theoretical reason that didn't exist. So I think it's important that, as a medical team, we can only act on the information we have in front of us. And sometimes we need to be thinking, okay, I'm going to expend this resource rather than withhold expending it. I just need to call to make sure I get more resources coming. If that answers that question.
Oh, it absolutely does. And I mean, that makes absolute sense. Something like blood, I got a bunch of walking blood bags running around. I can poke one and start draining. But like resources like a surgeon, resources like, a neuro intensivist, they can only handle so many people at one time. And they, especially like a surgery, there's at least 2 people working on them. And it's not over quick. So, how do I guess, should I put the burden on me, to, do the triage and get them, patients kind of in order for them? Or do I say, these 3 need surgery, go over there and let the trauma surgeon, let them handle it?
Well, so ideally, before the first patient goes back to surgery, that trauma surgeon is there helping you make that decision, right? They're not going to be waiting in the OR. They're going to be out there with you, helping identify that first patient they need to take back. And then beyond that, because a lot of times, as pre-hospital providers, we are, forced to kind of make the decision of who's leaving here first or who am I going to send to the surgeon first. And, to me, like the easiest answer up front is who is more unstable, right? If I have a patient who, all things being equal, same mechanism of injury, one of them's unstable, one of them's stable, obviously the unstable one's going first, or the more unstable one's going first. But, a lot of times, in my setting, I'm receiving this patient as a handoff. So the other thing I rely on a lot is I will rely on asking the medics that are handing out this patient, because they've been seeing this patient for 10, 20, 30 minutes, et cetera. What's been the trend? Like, who are you more worried about? Who is taking up more of your resources? And so if, again, same stability, but they're like, oh, like this patient I'm way more worried about, I'm going to trust their gestalt because they've been with the patient longer than I have. And then also you consider mechanism of injury. And then finally, previous treatments. So if you got two patients that are both hypotensive and tachycardic, one has received 3 units of blood, the other one has not. Well, obviously the guy that's already received 3 units of blood and it's still unstable, I don't think that giving him blood's going to help that patient. So maybe I prioritize the one that's already received those interventions to go to the surgeon to do the things that I can't do.
Yeah. Yep. That makes sense.
Well, one of the things you brought up was, prioritizing your resources, and do I withhold care, which, that is a great ethical dilemma to present in training. Hopefully, if you ever come across that in real life, hopefully, whatever you decide, it's probably not going to be, ideal, and you're going to have to live with whatever that decision was. However, great thing to have in training. But having been on both sides of that evac, sending people and then and being on the receiving end, luckily with an FST, with adult supervision, I can tell you that I've seen FSTs that had a certain number and they would not accept more than that. This is our capacity. We can accept 4 patients, 3 patients, whatever it is, and we have to be able to get them out within this amount of time because we don't have patient hold. And then I've seen FSTs that were like, okay, I understand that we really aren't set up to deal with these guys for the length of time we might get them, but I can't put that medic in that situation where he's taking care of these patients that we don't really have the capacity ourselves of doing. So how's he going to do that out of an aid bag? And they've received patients, beyond their capacity, and God bless them, because they really did, take that burden off of one of our medics and took it onto themselves. And let me tell you, anybody that does that, they're going to have any help that we can give them, to help take care of those folks until they're shipped out to better care.
Yeah. And I would imagine, whether military or civilian, there's going to be inter-facility, when a mass casualty event happens, there's going to be inter-facility communication based on like, hey, like we have room for 4. We have a neurosurgeon available. We can take, I don't know, however many of those. So we're kind of purging them out of the X, as it were, but there's going to be probably some reshuffling later on as well.
Yeah, and I can't obviously speak from the leadership command side, but I can tell you, yes, absolutely in practice with, large patient volumes, really anything exceeding, I don't know, around 10-ish patients or so, oftentimes they will send patients to multiple locations if those locations exist at the time, of course, depends what theater of war we're in, to not overwhelm any one facility, right? And then, so in addition to that, you got to think about what am I leaving versus where am I going, right? So if the facility I'm at has the capability to do blank, and the other facility also does, well, maybe I don't evac the patients that this facility can handle. I evac only the ones that don't have the neurosurgeon, et cetera, first, right? And then I think it's also important to consider what are the capabilities of the transport mechanisms you're sending. So like some, if you have just a standard ground ambulance with a brand new medic, probably the patient is intubated shouldn't go, in that ambulance is also taking care of 3 other patients at the same time. Maybe that's something for dust off or any asset with a critical care flight paramedic or above to take care of. And, I've seen it a couple of times as well, where in really chaotic CASEVAC situations, they'll actually send providers from the facility that from the departing facility. Like if there's an intubated patient, well, maybe we send an ICU nurse or an RT with that patient because, this CASEVAC platform is going to be overwhelmed as it is. So those are other things I've seen done when considering where and how to send patients.
Yeah. Rick, so you mentioned like the training aspect of it, having an expectant patient. You've been around a bit longer than I have, which is really impressive. We always win. And if we train any differently, then it'll destroy the confidence of the medic and then the force will crumble. I guess, how would you incorporate an expectant patient into a scenario which is absolutely believable? Essentially, every medic constantly says that, like, in war, people die, but we never train that way. How would you incorporate that into a scenario without just kicking the legs out from underneath this, guy who's very soon going to walk out the door?
Well, I mean, in one aspect, when you set up a mass casualty scenario, you are kicking his legs out from under him. So, I mean, the situation itself, it's not a mass casualty if you can handle it. If you have enough supplies, support, personnel, and if you do everything right, that is not a mass casualty. So by definition, it's overwhelming and it's going to overwhelm you. So knowing that you have that patient that's not dead yet, but he's on his way out. And then you have several others that can be helped. And one of the lesser wounded guys I like to have as being, the best friend of the guy that's about to check out. And that is going to, he's going to be focused on his buddy, and you're driving that medic, that distraction. He's going to try to get him to treat his buddy over everybody else, but he's got to make that decision. And usually I like to have at least one other, if not medic, then a medically trained, pretty squared away assistant with the guy so that he can have some assets to direct. So he's not doing everything by himself. So he has some assets to direct, and he directs. And then I also like to have limited space on the evac so that he can't get everybody out, and he has to prioritize. He or she, they have to prioritize. And then we run the scenario, and then we talk about it. And there's usually not a right answer. It is, hey man, have you thought of this? Have you thought of that? Hey, yeah, the guy died. You did not fail. He was going to die no matter what. This is all during the AAR. And look, man, this is a tough scenario. And the idea is that you don't do this alone. You recruit help around you. That's the lesson here. Because trying to do it by yourself, initially you may be doing it by yourself, but you need to recruit help as soon as you can. Because it is overwhelming, and you need to manage the situation until it's manageable. You need to work the problem until it's manageable. And then, you get the, hey, we'd only take 2. All right, well, this guy and this guy's going. Why? I'll tell you later. Get them on the bird. Okay, now we can reassess. Now who's going next? And this is all, and you talk about all the different aspects. When you're doing this, when we do it in the schoolhouse, we're doing it with medics. And we've got medics that are pretending to be teammates or whatever, but they're all medics. What we're not practicing is that command and control piece. We're not practicing the security, the tracking the ins and outs to the CCP, the having the staging area for me to go up there and triage the new arrivals, the communications with higher, the up and out, down and in, controlling access, the the management of that piece, we don't exercise. We do just the medical aspect of it. So we're doing just the medic setting up his CCP and triaging and treating and evacing. And that's the extent of what we can do where we train. At the unit, that's where they need to exercise the rest of that, because that's where the rest of the team is. That's where you have that higher echelon that can be on the other end of the radio, taking that call and simulating pushing assets or whatever for the exercise, and that's where that needs to be trained.
Yeah. Andrew, I'm willing to bet that you've practiced mass casualty at least once. What does a successful, like if in a training type scenario, right? What does a successful mass cal look like?
So I will say that typically we definitely have a bias in the at least in the U.S. training for mass cal, that we can always win, right? That every patient always survives if we play our cards right. But I think that, if we're truly trying to do a successful mass casualty, and by that I mean we're actually training people to how it might happen, I think we need to start including those scenarios where you are not gonna win every hand of cards, right? So I think a truly successful scenario, then, by that definition of actually preparing people to handle things, it has to include, as Rick talked about, the full spectrum of mass casualty management tasks, right? So it has to include leadership, has to include non-medical personnel, so that we can do that security, the movement, the communication, the command control. And then, you have to have well-defined training goals, because I think that a lot of times, especially when these drills are set up by the medical side, we say, every individual patient has these critical action lists that have to be done, and that's what we define as success. I think instead we need to take a step back and look at this, have our endpoints, our goals be a little more global. So basically, did rapid triage identify all immediate life threats? So your massive hemorrhage, your loss of airway. Did all patients with hemorrhagic shock receive blood within a certain time frame, if possible? Did we have accountability of all patients coming in and out of the CCP? Were evacuation assets prioritized accordingly, and were patients prioritized at least with a good thought process, instead of it being, again, each patient has their individual goals? I think we need to shift towards larger goals, because some of the patients aren't going to make it, and we need to design scenarios that way, where, again, the goals are broader as opposed to individual down and in focused.
Yeah. I mean, I think you're never going to get to ultra mass cal unless you can handle a half a dozen, like 4. Can you handle 4 guys? Then you probably could, with that same process, once you get that kind of nailed down, now we can expand out to more and more people, and at least thought process wise, you'll probably be more successful than what usually happens, which, let's run a mass cal, right? And the whole idea is I'm just going to smoke this guy and then make fun of everything he did wrong. But you're absolutely right. We need to have like training goals. Like, I think whoever's running the lane should know what success actually looks like in a realistic way. And probably be prepared to do the same thing for themselves, I would think, just to kind of keep them honest as well.
Well, I can tell you that, having done some mass casualty training, we did very little on the team mass casualty wise. We did medical training. We didn't do mass casualty training, and we had one engagement. We're over 6 hours. We had 6 all partner force, 6 dead, 17 wounded. And we never got medevac. We drove them out with us. So that's just a bad day at the office. I don't know how you train for that. I think when, had we done some training, I think it would have went smoother. It would have been more efficient. I don't know. I mean, the 6 guys that died were pretty catastrophic. the 17 wounded were everything from, guy needed a bandage to, oh my God, tourniquets, litter, chest seals, chest tube, whatever. So having that full, I think the ones that were going to survive were going to survive. So looking back, and thank God, because otherwise, I'd still be haunted by that. But I think we could have done a better job managing their treatment, their pain, and their evacuation had we had some kind of reversal. But when you run into something like that, that's just fate throwing a grenade in your foxhole, man. There's no way to prep for that, I don't think, adequately. And if you prep for that, then you're going to get a different situation, and you're not going to be 100% ready for that. But you need to do some training. You need to have, responsibilities delineated, and people knowing what they're responsible for, and what actions, what piece of the pie they need to take care of.
Yeah, absolutely. Just like any kind of battle drill, whether you like them or don't like them, it's all for a purpose. The more you practice it, the more you become familiar, the lower the stress level it is when you have to do it, and you're going to execute it much more successfully than if you just draw it on butcher block and everybody gives you the north-south and just go about your day.
Plus, you're in a bad area, bad neighborhood when medevac won't come. So you should probably plan for that.
Yeah. I wish they had told me that's what their decision was going to be before we left.
Yes, I too wish that.
They're shooting at us. Well, you're on your own, bud. Andrew, any final thoughts? Any things, like if you were king for a day, what would you change, I guess, about the triage process, and maybe some final quick thoughts about how you would change training?
Yeah. So if I were king for a day, what would I change? Well, I got to give credit where credit is due. So I'm helping out with a team that's already made tons of moves, both on the research side and then on the what's the word I'm looking for here? Admin, big leadership discussion side about how we do triage in the U.S. Military. And so, my thought, hearing all of that, seeing some of those discussions and seeing the movements that are trying to be made, is I would kind of change triage from this algorithmic, follow one of the, what's better, the start, the sieve, hey, let's simplify it, right? So 2-phase approach. So your first phase is binary, dying and not dying, stable and unstable. And then who needs life-saving interventions now? Like who has immediate life threats? And then second phase is your deliberate triage. And that's the more traditional triage that we think of. And we think of separated into 4 categories: your urgent, priority, routine. And then in some situations, you can start to call patients expectant. And then again, the other thing is emphasize focus on the basics, right? Emphasize, as Stephen Rush put out, that move, treat, transport. And then the other thing is just, and I think this is a point that doesn't get reinforced enough, and we've all touched on this, there's no such thing as doing this right? So like when you're doing triage, it's because you have more patients than you can handle immediately, and you're overwhelmed. And so there's no right way, there's no perfect solution. You do the best you can with the resources you have. So that's how I would, change triage. And I think we've already kind of, hit the nail on the head as far as how we would change training. I think we all recognize that we need to, include this as part of the, larger drills and not just be isolated medical drills. And then the only thing I would advise people who are trying to set these trainings up, because, oftentimes as medical planning, these are thrust upon us, right? The best success I've had getting, larger, non-medical unit involvement in these is by kind of emphasizing that the medical drills in a mass cal, your, security, patient movement, communication, those, those line up with the more, non-medical, KSAs of move, shoot, communicate, right? That they're not discongruent from each other. They can be done concurrently and kind of have, synchronize with each other, if you will. So I think you can, again, that's one way you can help convince the leadership and the non-medical side to get involved in your training, is by emphasizing that your goals are congruent.
Yeah.
I would say scare them. Show them that their unit is at risk if we don't do this training. And I think that kind of, we joke around and say scare them, but, when you go to the command, you show them that, hey, we're at risk because we have a training deficiency, and these are the bad things that could happen. And if you pitch that honestly, I don't know many commanders that would not allocate some training time and resources towards that. So absolutely, the training should be at the unit level. It should, at the medic level. I think when they do it at the unit level, they need to have some sort of medical buy-in. I mean, I can tell you we've had numerous, we're going to do this exercise and there's going to be a medical piece to it. Okay, bam, that guy's wounded. Okay, you put a tourniquet on, got him on the bird. Good job. Medical training done. Check, moving on. But if you are serious about this and you plan this up, it takes a medical person that knows how to run training to challenge that medic, to set up a scenario and challenge that medic in that medical scenario, so he gets the most out of that training, not just a command exercise, so to speak. And I would say challenge not only the medic, but challenge that unit, that command, on their decision-making process. Have the evac delayed, have it staggered, it can't take everybody. Have them make all those decisions, those command decisions, because as a medic, I'm making a recommendation, but that commander has to make that decision on, okay, I can't lose this guy. So how bad off is he, Doc? Does he really have to go? And at some point, that might be a command decision. The decision to drive everybody out of that bad place we were in, that was a command decision. And honestly, it was made because we got tired of waiting for something, a train that wasn't coming. So, when you set up that training, it has to have unit buy-in, and to get unit buy-in, you have to have commander buy-in at the end of the day.
Yep. Absolutely. Well, thank you guys. I really appreciate you guys jumping on.
Thank you.
Thank you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.